to finish the entire thing. If it takes me like 3 hours, then I'll sleep at 3 o'clock. But I'm going to finish everything and then only I'm going to do everything. Like, I'm not going to stop the stream until I've finished almost everything. I'm in page number 57 right now. I'll finish all the way until 96 or so, and then I'll finish the last ending part away from here onwards. Actually, let's just start off with the ending part and then we'll finish it off, and we'll then go on to from the starting part. We have vascular disorders we have to finish. We have to finish thyroid and breast, parathyroid, neck, and oral cavity. Neck and oral cavity. So those are the 5 basic topics which I need to finish, and even cancers also I need to finish. But okay, let's finish off neurosurgery in half an hour. Then cancers, until cancers we will finish in half an hour. Then after that, the rest in another 2 hours will take. So 3 hours we need to be finishing this, and after we finish this, I'm done, and I'll sleep, and I'll wake up next to before the exam, and I'll yeah. Okay, so 11:38 right now. Hopefully I'll be finished by 12:30, 1:30, 2:30, and this is my end goal. Okay. So neurosurgery, first we have intracranial hemorrhage. You have extradural, subdural, subarachnoid, and intracranial. Extradural is between skull and dura. Subdural is between dura and arachnoid. Subarachnoid is between arachnoid and pyometer, and intracerebral is within the brain parenchyma. So etiology, it is trauma for all of them, and in subarachnoid you have spontaneous also, and in intracerebral you have hypertension also. So most common vessel involvement is middle meningeal artery. In subdural it is bridging veins. In subarachnoid it's arterial aneurysm, and in intracerebral you have branches of middle cerebral artery. So extradural hematoma is caused by direct blow to the head. You have fracture of temporal bone, you have rupture of middle meningeal, and bleeding occurs between skull and dura mater. Hematoma will be formed. Hematoma compresses the brain, increases intracranial pressure. It causes coning of the uncus through that tentorous hiatus, and shift of midbrain towards the opposite side. Midbrain will be shifted to the opposite side. You have contralateral spinotracheal tract injury by sharp edges of tentorial cerebellum. So contralateral spinal tract injury, because there is a pressure which is going to the opposite side, and tectoral cerebellum sharp edges will cause the injury. So you have Kernohan's notch effect. On the same side of hematoma you have hemiparesis and pupillary changes. Opposite side you have cerebrum, so muscle weakness and all will be happening. The lucid interval is state of consciousness between 2 periods of unconsciousness. Immediately after injury there is transient loss of consciousness. Patient becomes normal, soon becomes normal. After 6 to 12 hours patient's condition will deteriorate. This is the time taken to develop raise intracranial pressure and its effects. So clinical features, you have lucid interval and hemiparesis on the same side of injury is noticed. Hutchinson's pupil, initially pupillary constriction, which is irritation of oculomotor nerve by uncal herniation. Later you have papillary dilatation, which is constrictor paralysis due to persistent compression on the oculomotor nerve. Then you have burr hole decompression, which is done on the side of Hutchinson's pupil, Hutchinsonian pupil. Then you have crushing striatum, which is bradycardia, hypertension, and respiratory irregularities. Sorry about that. Respiratory elongating, bradycardia, hypertension, respiratory irregularities. So investigations you do chest X-ray, you have temporal bone fracture. Then CT head you give by in case of biconvex hematoma. If it's there, then you have to check for CT head. So treatment, you immediate craniotomy and evacuation of the clots, and anticoagulants should be provided. Then you have subdural hematoma. It is trauma, acceleration or deceleration injury, and shaken baby syndrome. Then it is due to traumatic acceleration, deceleration, differential movement of brain with relate to skull. It results in stretching and tearing of bridging veins. Another thing, this is subdural is between the dura and arachnoid. Subarachnoid is below the between the arachnoid and pia. Intracerebral is within the brain parenchyma. Extradural is callus. Okay. Middle meningeal artery next dural, it is bridging veins here. Bridging veins will be occurring over here. So types you have acute subarachnoid hemorrhage, subacute subarachnoid hemorrhage, and chronic subarachnoid hemorrhage. Acute occurs immediately, subacute after 2 weeks, and chronic occurs after 3 to 6 weeks. So clinical features, you have raised ICP, confusion, disorientation, convulsions, and hypertension and bradycardia can also be complaints. Convulsions, hypertension, bradycardia. Increased ICP, confusion, disorientation, convulsions, hypertension, bradycardia. Confusion, disorientation, raised ICP, convulsions, hypertension, bradycardia. Okay. It can also be electrolyte imbalance and intracranial space occupying lesions. So investigations, you do CT, you have concavo, convex hematoma, and serum electrolytes. You have to do examination. So treatment, you have craniotomy and evacuation of clots and anticonvulsants. Then subarachnoid hematoma, it is caused due to intracranial aneurysm, hypertension, blood hysteresis, anticoagulation therapy, and arteriovenous malformation. All of them causes subarachnoid hematoma. So its types are spontaneous and traumatic. Spontaneous is rupture of perianeurysm, rupture of an hypertensive aneurysm. Then traumatic is rupture of vertebral artery. So clinical features, you have thunderclap headache, sudden onset severe headache with vomiting. Features of increased ICP, hemiplegia and dysphagia is seen. There is sudden loss of consciousness and eye changes, you have ptosis and dilated pupil. So thunderclap headache, raised ICT, hemiplegia, dysphagia, the sudden loss of consciousness and eye changes, you have ptosis and dilatation pupil in subarachnoid hemorrhage. Blood hysteresis, anticoagulation therapy, arteriovenous malformation, hypertension, and intracranial aneurysm. Okay. Spontaneous rupture of aneurysm, hypertensive aneurysm, rupture of vertebral artery. So it can also be differential diagnosis, meningitis, raised ICP due to malignancy infection. Investigations, you perform lumbar puncture to differentiate from meningitis, and CT scan and carotid angiography you can do. Treatment is coiling and clipping of the aneurysm. You have to excise the vascular malformation, craniotomy, and evacuation of the clot should be done. Then Glasgow Coma scan is a practical method used for assessment of impairment of consciousness in response to different stimuli. Okay, so this one table, I really cannot explain how much it is difficult to remember this. So first you have eye opening, verbal response, and motor response. Eye opening, spontaneous, to speech, to pain, and none. 4, 3, 2, 1. Verbal response, oriented, confused, inappropriate, incomprehensible, and none. 5, 4, 3, 2, 1. Motor response, obeys the command, localizes pain, flexes to pain, abnormal flexion, extension to pain, and none. Okay, so basically they will obey to the command. Whatever you tell them they can do means it is 6. If they localize the pain, then it is 5. And if they flex when you like, if there is a pain in some point, if you press on it, they will flex. If there is abnormal flexion, it is 3. If they extend whenever there is pain, then it is 2. Then it is none. No response means it's none. No response verbally means it's none. Eye opening also, if it's to pain, it's 2. To speech, it's 2. It's 3. And spontaneously, eye opening is 4. Verbal response, if they're oriented, then it's 5. If they're confused, then it's 4. If it's inappropriate, then it's 3. It's incomprehensible, it's 2. And if it's none, it is 1. Then total score is 15. Mild head injury is 13 to 15. Moderate is 9 to 12. And severe is less than 8. 9 to 12 is the only thing you need to remember. More than 12 is a mild head injury. Less than 9 is severe head injury. And then we have meningocele. This is a herniation of meninges through a weak point in spine where fusion has not taken place effectively. So features: it is present in spleen. Birth: it is soft, fluctuant, in transilluminatory swelling, expansal impulse on coughing or crying, located in the lumbosacral area and occipitocervical area. So its complication of ulceration and hemorrhages can occur. So investigation: you do CT head, MRI spine, and treatment: you do excision as early as possible and closure of the defect by plication and approximation of the muscles to be done. Then you have thorax. You have a flail chest where there is fracture of two or more consecutive rib, which each rib having two or more fracture site. Each segment is called flail segment, and pathophysiology: flail segment moves in the opposite direction to that of normal thoracic cage. During inspiration, flail segment move outward, and during expiration, flail segments move outward. Like inspiration will move inward, expiration will move outward. So derangements: you have paradoxical respiration, reduction in ventilatory surface area, because it's going out when it's coming. It's required to be going in, and it's going in when it's going to be requiring going out. So there is a reduction in ventilatory surface area. You have mediastinal flutter due to movements caused by kinking of great vessels. That's why there will be mediastinal flutter. Types: you have anterior, which is near the costochondral junction, lateral in the rib shaft, posterior in the costocervic transverse junction, costotransverse junction in the posterior, lateral in the ribs. In the anterior, you have near the costochondral junction. Costotransverse is the ribs and the transverse segment of the spinal cord. Something like this. Okay, so next we have problems. We have cardiac arrest, respiratory failure, hemothorax, and you have infections and ARDS. Investigations: you have chest X-ray to identify the fracture segment, arterial partial pressure of oxygen and carbon dioxide. Treatment: you have first aid, where you have a paradoxical movement of flail segment prevented by applying pressure using hand or the cloth. So you apply a cloth or a hand and you apply pressure and you prevent paradoxical movement. And then you have intercostal tubal drainage. You apply grips to the fractured ribs and you do antibiotic therapy you provide, and ventilatory support you provide with intermittent positive pressure ventilation. Okay, so moving on, we have tension pneumothorax. This is underlying lung injury. Upon inspiration, air gets pumped into the pleural cavity via valvular opening in the visceral pleura. Air continues collect in the pleural cavity. Lungs will collapse. Mediastinum shifts to the opposite side, and further decrease in the inline function occurs. So there is increase in pleural pressure. There is reduced venous return. There is decreased arterial and venous filling, and there is decreased cardiac output and cardiac function. Decreased pleural pressure, decreased venous return, decreased arterial and ventricular filling, decreased cardiac output and cardiac function. So basically, tension pneumothorax will lead to cardiac function loss because from pleural pressure. Okay, air continues to collect in the pleural cavity. Lungs will collapse. Mediastinum shifts to the opposite side. Further decrease in the inline function is there. So valvular function is there. Okay, so features: you have tachypnea, tachycardia, decreased breath sound, resonant and percussion, severe mediastinal and tracheal shift, cyanosis and hypertension, and dilated neck veins. So management: you do thoracocentesis via bone aerial immediately in the second intercostal space in the midline, and sterile glove is kept on the blunt edge of the needle to prevent inward sucking of air. You provide nasal oxygen and you do a lateral intercostal tube. Later an intercostal tube will be put. First you do wide bone needle, and then you also provide intermittent positive pressure, IPPV. IPPV is provided for this also. This is a flail chest and tension pneumothorax also. Then hemothorax: it is blood in the pleural cavity. It is biologically a trauma, leaking aneurysm, tumors of the lung, mediastinum. Post operative: it is pulmonary, cardiac and esophageal surgeries. Leak from the central venous pressure monitor line. So clinical features, it is pain in the chest, tenderness, difficulty in breathing, dullness on percussion, decreased breath sounds are there, and infection. Blood acts as a culture media for the bacteria. So complications, you have ARDS and respiratory failure. Investigation, chest X-ray, pleural tap, aspiration site is posteriorly at the tip of scapula at summit intercostal space, and it is, you have CT chest scan. Okay, then treatment, you give is intercostal tube placed in mid-axillary line in sixth intercostal space. You have antibiotic therapy, you have bronchodilators and thoracotomy, which you can do. Then emphysema thoracis is collection of pus in the pleural cavity. Because emphysema is never primary, secondary causes are there. From chest wall, you have wound, osteomyelitis of rib. From lung, you have pneumonia, tuberculosis, bronchiectasis. Post-operative, you have after thoracotomy. From esophagus, you have perforation and carcinoma. Below the diaphragm, you have subphrenic abscess. So pathology, initial conduction of serous fluid eventually becomes purulent. It becomes intrapleural clotting of pus with pleural thickening, which is mature empyema. So it leads to rigid, contracted, immobile chest with functionless lung. Rigid, contracted, immobile chest with functionless lung. It is frozen chest. So if pus operates through intercostal space, emphysema necessitans. Pus operates through intercostal space, emphysema necessitans. Then we move on to bacteria associated with empyema: Staphylococcus, Streptococcus, Pneumococcus, Pseudomonas, E. coli. So clinical features, you have pain in the chest, tenderness, fever. Features of toxicity: difficulty in breathing, dullness on percussion, absence of breath sounds, decreased chest wall movements can be seen. So pain in the chest, tenderness will be there, fever will be there, toxicity will be there, difficulty in breathing will be there, dullness on percussion if you do, there will be dullness because it is emphysema necessitans. There is thickening of okay. So never primary, secondary causes only are there. So it is from wound, osteomyelitis, pneumonia, tuberculosis, bronchiectasis, after thoracotomy, perforation, carcinoma of subphrenic abscess. All of them will lead to formation of emphysema necessitans. Streptococcus, Pseudomonas. Intrapleural clotting of pus with pleural thickening will be there. Pleural thickening is mature empyema. Frozen chest will be there. Pus will operate through the intercostal space, which is emphysema necessitans. Okay. Pain in the chest, tenderness, fever, features of toxicity, difficulty in breathing, dullness on percussion, absence of breath sounds, and decreased chest wall movements is noticed. And complications: frozen chest, emphysema necessitans, osteomyelitis of vertebra, pericarditis, mediastinitis, and bronchopleural fistula. So investigation, you can do chest X-ray, blood DSR, peripheral smear you have to do, diagnostic aspiration, pus culture and sensitivity, bronchoscopy, CT and MRI. So treatment, you have stages 1, 2, and 3. Stage 1, you give antibiotics, repeated aspiration, intercostal tube drainage. Stage 2 is rib resection, is Eloiser's method, respiratory physiotherapy. And stage 3, you have decortication. Thickened pleural sac is stripped from the lung by thoracotomy approach. So first you do the thoracotomy, then the thickened pleural sac is stripped. Then we have empyema necessitans, which is complication of empyema thoracis. Empyema perforatus through the chest wall, present as subcutaneous collection of pus. Etiology: it is neglected empyema thorax, and incomplete aspiration of pus will lead to empyema necessitans. Clinical features: there is a bulge in the intercostal space, impulse on coughing. You have restricted movement of the chest wall due to tenderness, dullness on percussion, and decreased breath sounds are also heard. Investigations: you do chest X-ray. Then you have a total leukocyte count which is increased, and ESR also you have to investigate. So treatment, you give antibiotic and antitubercular therapy. Empyema drainage is given by ICT, interchest tube, and pus culture and sensitivity also you have to provide. Then surgical empyema is collection of gas or air in subcutaneous or facial planes caused by lung injury, tracheal injury, chest wall injury, and after laparoscopic procedure. So types: it is localized, generalized, featuring pain, diffuse swelling of subcutaneous region, and palpable crepitus. Investigations: chest X-ray and neck. Treatment is treat the cause and ICT. Wait 1 second. What is ICT? Intercostal tube. drainage. Intercostal. Mm. Okay, so in localized, it is observed at the localized surgical lymphoma is at the site of trauma. Generalized is extensive distribution involving chest wall, neck, face, eyelids, etc. Injury to bronchus, esophagus, and mediastinum. Then we move on to Pancoast tumor, which is a peripheral lung carcinoma arising from apex of lung, invading brachial plexus, sympathetic chain, upper ribs, and vertebra. So it is brachial plexus it will invade, sympathetic chain it will invade, and upper ribs and vertebra it invades. It presents with intractable pain in the upper chest and the arm. So it's a peripheral lung carcinoma arising from apex of lung, Pancoast tumor. Superior sulcus tumor. So presentation, it is Pancoast syndrome will be there. Lower brachial plexus palsy will be there. Horner syndrome will be there. Rib erosion and apical shadow. Horner syndrome, because of sympathetic chain is there, no? It will invade. Rib erosion will, because this thing, and apical shadow will be there from chest X-ray or CT scan. MRI also. Okay. Then Horner syndrome is also called as oculosympathetic palsy. It is meiosis and enophthalmos, enhydrosis, and spinociliary reflex. Eye meiosis. Meiosis, enophthalmos, and hydrosis. Ptosis, and you have loss of spinociliary reflex. Enophthalmos. Exophthalmos is coming out, enophthalmos is going in. Okay, so investigations, you have chest X-ray, CT scan, bronchoscopy, and biopsy, CT guided biopsy, and MRI, which gives better visualization of the inward structures. Treatment, you give lobectomy, pneumonectomy, radiotherapy, chemotherapy, methotrexate. Then cardiopulmonary bypass and CABG. So cardiopulmonary bypass is function of heart and lungs. Lungs are temporarily replaced by heart and lung machine. It acts as pump and oxygenation. Heart is exposed through a midline sternotomy. Venous blood from superior vena cava and IVC is divided into heart and lung machine. From heart-lung machine, oxygenated blood is passed into the ascending aorta. Bypass of blood from heart and lungs. Blood should be heparinized to prevent clotting in the machine. And temperature is lowered over the heart by pouring cold saline, and ventilation is discontinued. Once procedure on the heart is complete, air in the heart chamber is removed. Coronary perfusion is restored. Then heart is made to beat spontaneously using the direct current shock. Then function of heart-lung machine is gradually lowered. Heart is allowed to take back its function. Correction of hypocalcemia and acidosis if it occurs, and protamine sulfate to reverse the effect of heparin. Then you have CABG, coronary artery balloon bypass grafting. Something like that. Bypass grafting, yeah. So indication, it is triple vessel stenosis. If all three coronary vessels are having stenosis, then you take the saphenous vein and you make another you connect it post the stenosis. Left main stem stenosis also. Chronic stable angina with persistent chest pain and block in more than 70%. If the coronary artery block is more than 70%. Stable chronic angina with persistent chest pain. So graphs used veins, you have long saphenous vein, short saphenous vein, and cephalic vein. Between, okay. Then artery, you have internal memory artery and radial artery. Only if ulnar artery is patent. If ulnar artery is not there, then you cannot take radial artery. Internal memory vein, yeah, you can take. And technique. It is done under cardiopulmonary bypass. Complication, graft thrombosis, atherosclerosis of the graft. Graft also may undergo thrombosis. Atherosclerosis also may occur in the graft also. Anesthesia and adjuvant therapy. I will read this. I'll read this on my own. Okay, I'll just finish this. Anesthesia, adjuvant therapy, brachytherapy, radiation given to the source close to the tumor. It is a curative radiotherapy placed in the chest cavity. It is called intracavity RT. Given using iridium 182, cesium 137. Indications: oral cavity carcinoma, penile carcinoma, breast carcinoma, cervical carcinoma, and bladder carcinoma. Advantages: it gives localized effect of sparing of adjacent tissues. Then regional anesthesia makes a specific part of the body numb to relieve pain or allow surgical procedure to be done. So types, you have spinal anesthesia, also called subarachnoid block, epidural anesthesia, and you have nerve blocks. Mode of action, you have a temporary block of conduction of action potential through the nerves. Advantages: you have general anesthesia is avoided, consciousness is retained, patient can have food earlier and after surgery, and technically it is simpler. Drugs used, you have cocaine, procaine, lignocaine, pilocaine, bupivacaine, and ropivacaine. All icaine. All cane. Okay. Spinal anesthesia. These are local regional anesthesia. Spinal anesthesia is injection of local anesthesia into subarachnoid space. Loss of sympathetic tone, loss of sensation, loss of motor function. Tone will go, sensation will go, motor function will go. So position, you have lateral decubitus position, fully flexed, open the interluminal space. It is economical. Hypertension reduces the bleeding and respiratory complication is less. However, disadvantages: CSM leak, meningism, and infection and paraplegia. However, it is rare. Contraindication in cardiac patient: raised intracranial pressure, sepsis, and kyphosis, scoliosis. All of these are contraindication for this, because you cannot locate the pin in this one. Sepsis means infection is more common. Raised ACP may precipitate coming, and basically it will gush out and it will not allow the proper injection itself. Cardiac patients, of course, you don't do it. Then epidural anesthesia, you have injection of anesthesia in space between dura anteriorly and ligamentum flavum posteriorly. This place has got negative pressure, extends from foramen magnum to sacral hiatus. Advantages: used for continuous repeated prolonged anesthesia. Between dura and ligamentum flavum. Anteriorly there is dura and posteriorly there is ligamentum flavum. This space has got negative pressure, extends from foramen magnum to sacral hiatus. Continuous repeated prolonged anesthesia. Okay, nerve block, it is a method of producing anesthesia. It can be surgical or non-surgical. Surgical can be cutting or destroying specific nerves to prevent them from conducting impulses. Surgical nerve blocks may be permanent. Non-surgical injection of anesthetic around a specific nerve or a bundle of nerve prevents the nerve impulse from reaching the CNS. Lasts for 12 to 36 hours depending on the type of anesthetic used. So indication: it is pain from labor and childbirth, cancer-related pain, arthritis pain, lower back or sciatica, migraine, chronic regional pain syndrome, neck pain caused by herniated disc, phantom pain after amputation, pain from spasms, excessive sweating, hyperhidrosis, Raynaud's phenomenon. So I finally understood what Horner's anhidrosis is. This means no sweating. I remember now. Ptosis will be there, no sweating will be there, eyes will be going in, meiosis will be there. There will be mydriasis, is opening, meiosis is pinpoint. Ptosis will be there, loss of spinociliary reflex. So, okay, so going on, examples, you have examples of nerve block. You have inferior dental nerve block for tooth extraction, intercostal block, medial and ulnar nerve block, brachial plexus block, and sciatic nerve block and femoral nerve block also can be there. Ketamine used to induce dissociative anesthesia, form of anesthesia characterized by catalepsy, catatonia, analgesia, amnesia. So side effects, you have hypertension, laryngospasm, apnea. Xylocaine, which is also known as lidocaine or lignocaine, Local anesthetic drug, antiarrhythmic drug, pharmacokinetics, metabolized by drug, normal. Normal. Dosage is 4 mg per kg for 90 minutes. Can be used with or without epinephrine. With epinephrine has longer duration of action because there is a relatively less field it will create, so less amount of it will go and become metabolized and become active. So it is not given with epinephrine at the place of end arthritis like gland spinous, ear lobule, nose tip, and fingers and toes because it will lead to gangrene. Epinephrine at these points will lead to gangrene. So side effects: postural hypotension, tinnitus, headache, and circumoral anesthesia. So uses you have topical, infiltrative block, field block, nerve block, epidural, spinal, and BS block, which is intravenous regional anesthesia. So indications: you have upper limb surgeries, lower limb surgeries are indications. Duration is for 2 hours. Side effects if hypertension and convulsions. So in the procedure, limb is occluded with a tourniquet. Pressure must be 30 mm more than systolic BP. Xylocaine is injected into the vein. Xylocaine with adrenaline should not be used, however. Then there are a few other topics over here which I do want to finish, but I'll do it. Come back. I'll do it later. Maybe tomorrow. Tomorrow I can just check this out. Minimally invasive, maybe. Laparoscopy also I need to do. This is an important one. And we go all the way back. A lot of these things I've already known. So breast, of course, we have to do. Breast is the most important thing I need to do right now. Thyroid, somewhat okay. I'm okay with missing it. But breast is very much important. Varicose is very much important. Those two are the two topics which I have not been able to finish. Okay, so going on, you have arterial disease, thromboangiitis obliterans, which is Buerger's disease, non-atherosclerotic inflammatory disease of small and medial distal veins. Cell-mediated sensitivity to type 1 and type 3 collagen is there. Cell-mediated sensitivity to type 1 and type 3 often presents as renal phenomenon with microabscesses. So etiology, it is you have hormonal influence is there, hypersensitivity to secrets is there, altered autonomic functions, and recurrent minor feet injuries. All of this will lead to thromboangiitis obliterans. Hormonal influence, hypersensitivity to cigarettes, altered autonomic functions, and recurrent minor feet injury. So pathogenesis: smoke contains carbon monoxide and nicotinic acid. High carboxyhemoglobinemia initially increases vasospasm and hyperplasia of the intima. Thrombosis and so obliteration of vessels occur. Commonly, medium-sized vessels are involved, which finally leads to panarthritis. Usual involvement is segmental panarthritis can occur. Eventually, artery, vein, and nerves are together involved. Nerve involvement causes rest pain. If the nerve is involved, it leads to rest pain. So, patient presents with features of ischemia in the limb. Ischemia will be there in the limb. Then once blockage occurs, plenty of collaterals will open up. The blockage will happen, then collaterals will open up depending on the site of blockage, either around the knee joint or around the buttock. Once collateral open up, through these collaterals, blood supply is maintained to the ischemic area. Because there are collaterals, they will supply the blood to the ischemic area. It is called as compensatory peripheral vascular disease because there is compensation. If continuation of smoking, disease will progress into decompensated peripheral vascular disease called as critical limb ischemia, where there is pain, ischemia, and gangrene. So you have classification of TAO. Type 1 is upper limb, type 2 is leg and feet, type 3 is femoropopliteal, type 4 is iliofemoral, type 5 is generalized everywhere. So clinical features: most common in males, smoker's disease. Okay, so most common in males, most common site is lower limb, intermittent claudication of foot and calf is there. Recurrent superficial thrombophlebitis is there. Absence of pulse distal to proximal, that is dorsalis pedis, posterior tibial, popliteal and femoral artery. Pulse will not be there, and it may present as Raynaud's phenomenon. Okay, so etiology, of course, hormonal influence is there. Hypersensitivity to cigarettes will be there. Altered autonomic functions is there. Recurrent minor feet injury. Those 4 etiologies you have to remember. Vasospasm, hyperplasia of intima, thrombosis, obliteration. Once blockage occurs, collateral open up and knee joint or buttock. Once collateral open through this blood, it is called compensatory. Collaterals is open means it's compensatory. Okay, so investigations, of course, you have to investigate blood sugar, ankle brachial pressure index, arterial Doppler, and duplex scan, Doppler plus B mode ultrasound. You have transfemoral retrograde angiogram. If femorals is not felt, you have transbrachial angiogram. So treatment, you have quit smoking. Drugs, you give low dose aspirin for antiplatelet action. You have give clopidogrel and statins. Cleostazole, which is a PDE inhibitor, improves circulation and is the ideal drug. Sedatives and analgesics, you give nifedipuril. Nifedipuril, which alters tissue metabolism, useful in intermittent claudication. Gene therapy, you give intramuscular VEGF injection, which promotes angiogenesis. So we also take care of the limb. Burgess position, head of the bed is raised, foot end of the bed is lowered to improve the circulation. We take care of the feet, which is chiropedy. Avoid exposure to feet to cold temperature. Avoid minor pricking injuries to feet. Heels, 2 cm heels to decrease the work of the calf muscles. Surgery, you do omentoplasty, revascularization of the affected limb. Profundoplasty also can be done for blocking the profunda femoris artery. Lumbar sympathectomy to cause vasodilation and increase the cutaneous perforation, and of course amputation. Omentoplasty, profundoplasty, blockage in the profunda femoris artery, lumbar sympathectomy and amputation. Okay, limb ischemia, let's go on. So it's caused by atherosclerosis, acute embolism, arteriopathy, Burgess disease, Reynolds disease, Takayasu disease. They are the arthropathy. Limb ischemia, atherosclerosis, arthropathy, acute embolism, diabetes, scleroderma, and physical agents like trauma, tourniquet, radiation injury. Then there is Fontaine's classification of limb ischemia, stage 1, 2, 3, and 4. Stage 1 is asymptomatic, stage 2 intermittent claudication. Well compensation can walk more than 200, poorly compensated can walk less than 200. So stage 3 is rest pain, and stage 4 is gangrene ischemic ulcer. So functional limb ischemia, blood flow is normal when limbs are at rest. Blood flow will not increase during exercise. Muscle discomfort in the limb will increase by exercise and relieved by rest within 10 minutes. Normal at rest will not increase during respiration. Discomfort increases by rest, relieved by rest, increases by exercise and relieved by rest within 10 minutes. Then you have critical limb ischemia, which is persistently occurring ischemic rest pain for 2 weeks, requires a longer analgesic for more than 2 weeks, associated with ulcer, gangrene, ankle systolic BP less than 50 mmHg, toe systolic blood pressure less than 30 mmHg. Then you have ABPI, ankle brachial pressure index. It is checked in supine position. If it's more than 0.9, it is normal. 0.7 to 0.89 is mild ischemia. 0.5 to 0.569 is moderate ischemia. Less than 0.5 is severe ischemia. Less than 0.3 is tissue necrosis. 0.3 tissue necrosis, severe ischemia. Severe, mild, moderate. Severe, moderate, and mild. Then 0.9 is normal. 0.1 is 1.1 and 1.2. Yeah. Drawbacks: makes vessel incompressible during high ABPI, more than 1.3. Vessel wall calcification is there in diabetes, then you cannot check ankle brachial pressure index, because calcification will give a false increased pressure. Then, so yeah, critical limb ischemia pursues aspirin, antiplatelet action, clopidogrel, statins you can remember, PDE inhibitor, uh, improves circulation, which is the ideal drug. Philostazole is the ideal drug. Sedatives and analgesics, nifty rule, which alters tissue metabolism, and gene therapy, intramuscular VE gene, vesicular endothelial growth factor. Share of underplasty lumbar sympathectomy. If femoralis is not felt, it is transbrachial angiogram. Blood sugar, ankle. Okay. So here also, yeah, ankle bracelet index to be checked in supine position. More than 9.7 say more, 0.75 say more than 0.7, more than 0.5, more than less than 0.5, and less than 0.3 is necrosis. Then we have 1 second. Fine, let's finish this fast. Oh my god. Pre-gangrene, you have tissue changes indicating blood supply is inadequate. You have rest pain, color changes, edema, hyperesthesia with or without ischemic ulceration. Gangrene is microscopic death of tissue in situ with putrefaction. Dry gangrene, you have coagulative necrosis due to gradual slowing of bloodstream due to clear line of demarcation between healthy and granulation tissue is there. Microscopic death of tissue in situ with putrefaction. Microscopic death of tissue in situ with putrefaction. So pre-gangrene is tissue changes indicating that blood supply is inadequate. Rest pain is there, color changes is there, edema is there, hyperesthesia with or without ischemic ulceration. Dry gangrene is coagulative necrosis is there, gradual slowing of bloodstream is there, clear line of demarcation between healthy and granulation tissue. Then wet gangrene is there, which is a liquefactive necrosis due to both arterial and venous block. It has superadded infection and putrefaction. There is no clear line of infection. Liquefactive necrosis, both arterial and venous block will be there, superadded infection and putrefaction. Then you have line of demarcation, junction between the viable and dying tissue, indicated by a band of hyperemia. Hyperesthetic region due to irritation of exposed nerve endings is there. So it is line of demarcation. So necrosis is microscopic cell death, sequestrum is dead bone in situ, slub is dead tissue in situ. So levels of arterial obstruction, you have aortoiliac block, claudication in the buttocks, thigh and calves, absence of femoral and distal pulses. Distal pulses will be absent. Bruit will be heard over the aortoiliac region. Lecce syndrome, which is impotence due to effective perfusion through the internal iliac artery, leading to decreased perfusion to penis, leading to erectile dysfunction. Okay, arterial block, claudication will be in buttocks, thighs and calf. Okay. Internal artery obstruction, you have claudication in thigh and calf, bruit over the internal iliac artery. Aortoiliac region, here it is only iliac region artery. Absence of femoral and distal pulses will be there. Femoropopliteal obstruction, calf pain, palpable femoral pulse, absent distal pulse. So distal obstruction, palpable femoral pulse, femoral and popliteal pulse will be absent, or ankle pulse will be absent. Claudication, palpable femoral pulse. Okay. So clinical features, you have marked pallor, cyanosis, diminished hair, brittle nail with transverse ridge, ulceration and gangrene, tenderness and temperature will be cold. Pallor, cyanosis, diminished hair, brittle nail with transverse ridges, ulceration, gangrene, tenderness and temperature will be cold. Okay. Tests for arterial obstruction, you have delayed capillary filling, you have delayed venous filling, cross-legged test. Okay, let's go one by one. So delayed capillary filling is that there will be branching in the nails and toe pulp on pressure. Delayed refilling after the pressure is released. And delayed venous refilling, you have two fingers are placed over the vein. Nearest finger to the heart is moved away to empty the vein. Distal finger is released to observe venous refilling. So 2 fingers are the same. It's done in ascites also. You keep it. Distal part you remove. After proximal part to the heart you remove. Then distal part you remove to see how fast it will refill. Cross leg test is false incest. Sit with the legs crossed. Popliteal fossa of one leg will lie against the knee of the other. Okay, so oscillatory movement of the foot is seen in synchronous with popliteal pressure. This movement is absent in blockage of popliteal muscle. Okay, give me a second. Okay, disappearing pulse syndrome is exercising the limb after feeling the pulse disappears due to claudication after exercise. Burgess postural test lie supine. Normal individual plantar aspect remains pink even at 90-degree elevation. However, limb ischemia plantar aspect shows marked pallor. The angle in which the pallor develops is a Burgess angle. If this angle is less than 30 degrees, it is severe ischemia. Then you have Anson's test, which is scale-in maneuver. Patient is sitting on a stool, radial pulse is felt. Take deep breath, ribcage moves upward and narrows the cervico-axillary channel. Turn the face to the same side. Scalene anterior muscle contacts, narrowing the scalene triangle. If radial pulses disappear or is feeble, then it's cervical rib or scalenus anticus syndrome. Okay. Scalene anterior, scalenus anticus syndrome or cervical rib. Then you have costocervical compression maneuver, which is Falconer test. Distal radial pulse disappears when patient draws shoulder backward and downward. Subclavian artery gets compressed between first limb and the clavicle. Feeble or absent radial pulses. Falconer's test, and you have hyperabduction maneuver, Wright's test. Affects limb hyperabduction. Affected limb hyperabduction is there, means feeble or absent radial pulse. Compression of artery by pectoralis minor tendon is noticed. Allen's test is check patency of radial and ulnar arteries. Both arteries are compressed near the wrist for 1 minute. Palm is clenched. One of the arteries is released and head of the hand is noticed. Normally hand becomes pink or flushed in no time. However, if there is obstruction, hand remains pale. Not tail, pale. Okay, limb ischemia treatment. Then after that, gangrene. Intermittent claudication, yes. Lumbar sympathectomy, NTAO, and Hiram. Renal phenomenon, yeah. Okay. Diabetic foot, okay. Vascular lesions is most important. This is the one topic which even I'm not confident with. Fistula, venous disease, varicose vein, body tunnel, yeah. Then lymphatics. Lymphatics is okay. Hodgkin's, I don't know. Basically, melanoma, tribandimus, Kaposi sarcoma, yeah. Facial maxillary, this one, yeah. Nash surgery, yeah. Lentigious staples. Oral cavity is another important thing. I have done this a little bit before from this textbook itself, so I'm not that worried. Pleomorphic carcinoma, athentinema, cystic hygroma, very much important. Brachial fistula, tuberculous lymphadenopathy, I've done it a little bit. Cold abscess, yeah. Carotid body tumor, I don't know that one. Thyroid, I'm pretty confident I can do it very fast. Tomorrow morning is the only time I do thyroid. And carcinoma of the breast. Yeah. All of them I know, but again, problem is I've forgotten all of them. It's such a unfortunate thing, man. Okay, so there's a 60, 50, 40, yeah. Okay, 650. Page number 52. Honestly, I need to go fast. I want to sleep by like 2 at least. No, I want to finish everything and sleep, to be honest. Last minute, maybe thyroid, I will leave a little bit. But I really don't want to leave anything because I've done it already, man. Okay, so investigations for arterial disease have segmental pressure measurement, segmental BP at multiple level, upper and lower level, Doppler to localize the site of lock, duplex scan to combine Doppler and B, localize and check collateral circulation, angiography for Sleden technique, left brachial artery, trans aortic angiography, transbrachial angiography can be done. Angiography can be done. All of these points not even required. Digital subtraction angiography. Dye is injected. It is easier and large dosage of dye is required in vein, but artery is difficult, but small dosage of dye is sufficient. Only vascular system is visualized. Other system are eliminated by the computer subtraction. Small lesion can be observed better. Disadvantages: cost factor. Then complication: anaphylaxis, thrombosis, bleeding. CT angiogram, MRI angiogram, ankle brachial pressure index, duplex scan, Doppler, segmental pressure management, segmental BP measured at multiple levels, angiogram. Treatment of lymphedema: you quit smoking, exercise, control diabetes, mellitus, and hypertension. Percutaneous transluminal balloon angioplasty, bypass surgery. Different grafts are used: Dacron, human umbilical vein, saphenous vein, polytetrafluoroethylene, PTFE. Thrombectomy, fundoplasty. Okay, gangrene is microscopic death in with putrefaction. Sites, limbs, appendix, bowel, testis, gallbladder everywhere. So causes secondary to arterial coagulation, atherosclerosis, emboli, diabetes mellitus, TFO, ergot toxicity. So infective, it can be gangrene or 4 years gangrene. In trauma, physical, it can be burns, frostbite, irradiation, and electricity. So clinical features: color changes will be there, pallor, brownish black due to disintegration of hemoglobin. There is absence of pulse, loss of sensation, loss of function. So types: you have dry gangrene, wet gangrene, and line of demarcation. Investigation: hemoglobin percentage, blood sugar, arterial Doppler, angiogram, ultrasound abdomen, status of aorta to check. Sleder's technique in angiogram. Treatment: you have limb saving methods, you have drugs, antibiotics, vasodilators, low dose aspirin, dipyridamole, and pentoxifylline. So treatment: you treat the cause, diabetes, infection, etc. You take care of it and toes. It is kept dry, avoid minor injuries, take proper footwear, microcellular rubber footwear, MCR. Localized pus drainage is to be done. Surgeries to improve perfusion: you have lumbar sympathectomy, omentoplasty, fundoplasty, iliopopliteal thrombectomy, arterial graft bypass. You have life-saving procedure like amputation, Ray amputation, Belloni Burgess amputation, Aboni amputation, modified Symes amputation. Then intermittent claudication is crampy pain in muscles of vein due to arterial accumulation of metabolites like lactic acid and substance P. Pain develops only when muscle is exercised, disappears within 5 minutes after rest. After exercise, you have Bart's classification: grade 1, pain after walking, distance is claudication pain. Continue to walk, it will increase blood flow, opening the collateral, pain causing metabolites are washed away, substance P and substance lactic acid will washed away, and pain will subside. Grade 2 is persistent even on continuing walk, but however they can walk with effort. Grade 3 has rest pain also may be noticed. Rest pain is maybe grade 4. I don't know. I think only 3 grades are there as far as my remembrance. Rest pain is continuous ache in the calf, feet, and toe due to ischemic nerve injury. Pain increased on lying down and foot elevation. Pain reduces on hanging the foot down due to ischemic nerve injury. Pain is alleviated by holding the foot in hand. Suppression of pain transmission. Continuous ache of calf, feet, and toe. Ischemic nerve injury. Okay, so then we move on to lumbar sympathectomy, which is indications are TAO, promote healing of cutaneous ulcers. I think hyperhidrosis of lower limb, make flaps to heal better after amputation. My phone is actually heating up a lot. The principle is lumbar sympathectomy leads to increased cutaneous blood perfusion. So, under general anesthesia or spinal anesthesia, extraperitoneal approach, you transverse incision is provided at the loin at the level of umbilicus. You divide the external internal oblique muscles and split the transverse abdominis. Inferior vena cava on the right side, aorta on the left side are identified. Sympathetic chain is identified over the transverse process of lumbar spines. L2, L3, L4, L5 ganglia are removed. L2 is identified by larger size and more rami. L1 is retained on the one side in bilateral case. If it is removed on both sides, it will lead to failure of ejaculation, sterility, and dry ejaculation. This is lumbar sympathectomy. TAO promote healing hyperhidrosis of lower limb, make flaps to heal better after amputation. Complication: injury to IVC and aorta, dry ejaculation, paradoxical gangrene of the opposite limb, injury to bowel and ureter. So limitation effects are only temporary, 3 to 4 weeks. Long-term results are doubtful. Sympathectomy. Okay. Anium is dacryolis spontanetica, painful constriction of fifth lobe followed by bilateral spontaneous auto amputation few years later. More common in male, history of running barefoot, fissure develops at intrapharyngeal and becomes fibrous gland, necrosis of little tube. Treatment: you have Z-plasty and amputation yourself. You remove the fibrous gland, Z-plasty. Then you have Raynaud phenomena, which is episode localized vasospasm of small vessels of hand and feet, leads even temperature and color changes. Initial pallor, which will be vasospasm, then it is blue, which is venous congestion, and then it is red, hyperemia due to rapid blood flow. It is caused by working with vibrating tools, collagen vascular disorders like scleroderma and vasculitis. Other causes, you have Sclavin syndrome and Burgess disease. So the features, you have bilateral, most common in young females. Usually medial 4 digits and palm are involved. The thumb is spared. Features of pallor, cyanosis, rubor, painful red engorgement can be seen in recovery. Pulses, peripheral pulses are felt, absent in upper limb TAO. Repeated attacks are common. So investigations, you have digital subtraction angiography, arterial Doppler or duplex scan, antinuclear antibody assay, and nail fold capilloscopy. Identify abnormal tissue, differentiate between primary and secondary RP. And treatment is treatment of the cause, avoid precipitating factor, protection from this cold, avoid smoking, avoid vibrating tools, vasodilators, pentophilin and low dose aspirin to be provided, and localized digital sympathectomy can be done. Then you have diabetic foot or gangrene. Ulceration are associated with neuropathy and or peripheral artery disease of the lower limb in a patient with diabetes. Midget's classification is grade 0, 1, 2, 3, 4 and 5. 0 is pain only, 1 is superficial ulcer, 2 is deep ulcer, 3 is ulcer with bone involvement, 4 is forefoot gangrene, 5 is full foot gangrene. So pathogenesis: high glucose lead to good culture media for bacteria, diabetic microangiopathy, blockage of microcirculation leading to hypoxia, diabetic nephropathy, minor injuries to the foot are not noticed, infections will develop, and atherosclerosis, diabetic atherosclerosis, reduced blood supply leading to gangrene, and increased glycosylated hemoglobin leading to defective oxygen dissociation leading to hypoxia. Then clinical features: you have pain, ulceration, absence of sensation, absence of pulsation, and abscess formation and septicemia. The deal is pain, ulceration, absence of sensation, absence of pulsation, abscess formation, and septicemia. Investigations: you have blood sugar, urine ketone bodies, X-ray to rule out osteomyelitis, pus culture and sensitivity, Doppler study you can do, angiogram you can do, glycosylated hemoglobin estimation also can be done. Treatment: you can give antibiotics, drugs, vasodilators, pentoxifilin and dipyridamole, low dose aspirin. Then you can control diabetes, surgical debridement of the wounds can be done, Amputation of the gangrenous area can be done. Care of feet, avoid injury, avoid use of microcellular rubber, MCR footwear. Keep the feet dry and clean. Oh my god. Oh my god, another 40 pieces will take around 2 hours. Unfortunate. Okay. Vascular lesions. You have hemangioma, which is a benign vascular endothelial tumor, most common in girls, 3:1 ratio. Onset is few weeks after birth. Classification, you have capillary hemangioma and cavernous hemangioma. So complications, you have hemorrhage, DIC, ulceration, infection and septicemia. Investigations, you can do Doppler CT angiogram to find out the feeding vessel. Treatment, you can do sclerosant therapy, ligation of feeding artery leading to shrinkage of the hemangioma, therapeutic embolization and laser ablation can be done. Then capillary hemangioma, strawberry or raspberry hemangioma. Wait a second, I didn't read through. Actually, I'm going to take a break. Give me a second. Okay. Let's see. So genuinely, I haven't slept at all because there's so much I need to still do, but let's just keep on explaining. Okay, so you have capillary hemangioma, strawberry raspberry hemangioma, most common site in the head and neck. Child is normal at birth. At 3 weeks, red marks will appear rapidly, increasing in 3 months. Eventually, intravascular thrombosis and mast cell infiltration will occur. Clinically, it is a compressible, warm, bluish surface. Bleeding can occur after minor trauma or ulceration. After 1 year, it slowly disappears. So, treatment is allowed for spontaneous sedation. You give a pulse diode laser and surgical excision and reconstruction. Intralesional steroid therapy can also be provided, and indication for surgery, you have uncontrolled growth, functional impairment of vision or hearing, and cavernous hemangioma is present at birth. It increases in size gradually, located in the head and neck, tongue, limbs, liver, and other internal organs. Consists of multiple venous and lymphatic channels. It is a compressible, warm, bluish surface. Okay. Then arteriovenous fistula. It is an abnormal communication between artery and vein. You have congenital arteriovenous malformation and you have acquired or traumatic arteriovenous malformation. Congenital is located in limbs, lung, brain, circle of Willis, and abdominal organ. It features warm girth, lengthened limb, and more blood flow will be there. Because there is more blood flow, you have dilated arterialized varicose vein, and you have hyperdynamic circulation, which causes increased cardiac output, which leads to congestive cardiac failure. So investigations, you have magnetic resonant angiogram and Doppler study you can perform. So treatment, you have indications for surgery, you have hemorrhage, congestive cardiac failure, and functional disability. And you have surgical ligation of feeding vessels, complete excision of the lesion can be done, therapeutic embolization can be done, and amputation can be done. And in acquired cases of arteriovenous fistula, the causes are therapeutic, trauma and therapeutic. You have seminofistula created for renal dialysis to achieve arterialization of veins and to have hyperdynamic circulation. So it changes at the level of fistula. You have aneurysmal sac, which is continuous thrill and machinery murmur can be seen, and you have changes distal to the fistula. Due to diversion of arterial blood, distal parts become ischemic. High BP leads to arterialization of the vein, leading to varicosity. So, changes proximal to the fistula, you have hyperdynamic circulation leading to cardiac failure, and you have Branham sign or Nicolandoni's sign. When pressure is applied proximal to the fistula, swelling will get reduced in size. Thrill and bruit will disappear, and pulse rate and pulse pressure becomes normal. So investigations, you can do Doppler study and MR angiogram. Treatment is excision of the fistula and reconstruction of artery and vein with a graft. Okay, so acquired and congenital. Yeah, it can be limbs, lungs, cycle of Venice, the girth and length and limb, abdominal dilated, increased cardiac output, congestive cardiac failure, MR angiogram, Doppler study, indications of surgery of hemorrhage, congestive cardiac failure, and functional disability. And surgical ligation of feeding vessels can be done, complete excision of the lesion, therapeutic embolization, and amputation can be done. Acquired arteriovenous fistula, it's caused by therapeutic and trauma, and you have fistula created for renal dialysis to achieve arterialization of vein and have hyperdynamic circulation. Okay, so features, you have changes at the level of fistula, you have aneurysmal sac, continuous thriller machinery murmur can be heard. Distal to fistula, you have diversion of an arterial blood, distal part becomes ischemic. Distal part will become ischemic, high pressure of blood will be there, arterialization of veins will be there, and varicosity formation will be there. So proximal to fistula, you have a hyperdynamic circulation, it is a cardiac failure sign. Brahman sign is pressure applied, swelling gets reduced in size, thrill and bird will disappear, pulse rate will be normal, and pulse pressure becomes normal. Doppler study, MR angiogram, excision of the fistula and reconstruction of artery with a graft is normal. Therapeutic or common. Simono is created for renal dialysis. Then in venous diseases, you have deep vein thrombosis, thrombophlebitis. It is a sinusoid, semi-solid clot with high tendency to develop pulmonary embolism and sudden death. Causes trauma to leg, ankle, and thigh, immobility, bedridden patient, long distance air or bus travel. You have pregnancy, PPRM, OCP use, post-operative thrombosis, polycythemia, deficiency antithrombin, and protein CNS. Sites of DVT, you have pelvic vein, internal iliac vein, PVD in female, leg veins, iliofemoral vein, popliteal vein, soleal vein. It is the most common. Soleal vein is most common. Then upper limb vein, you have axillary vein thrombosis. Clinical features, you have fever is the earliest sign, tender, warm, shiny calf. Halfman sign is the ossiflexion of foot with extended knees causes tenderness in calf. Halfman sign. Then you have Moses sign, which is gently squeeze out the lower part. Gently squeezing is painful. Squeezing should be gentle or else dislodge the thrombus. And features of pulmonary embolism, chest pain, breathlessness, hemoptysis, light and test. Application of the tourniquet at the saprophemoral junction. Patient is made to walk without removing, and after the walk, the limb is elevated. Prominence of superficial vein indicates DVT. Fever, tenderness, warm, shiny skin, all-vein sign. Last reflection, Moses sign, pulmonary embolism signs. Okay, pelvic vein, internal iliac vein, PID in female, and leg veins, you have iliofemoral and femoral vein, popliteal vein, soleal vein. Upper limb vein, you have axillary vein. Then differential diagnosis, you have ruptured biccuses, ruptured plantaris tendon, and calf muscle hematoma. So investigations, you have venous Doppler with duplex scanning, venogram. Radioactive iodine 125 fibrinogen study can be done, and venous perforation scanning can also be done. So treatment is rest bandaging entire limb with the crepe bandage, anticoagulants, low molecular weight heparin, warfarin, phenydione, thrombectomy using Fogarty's catheter and IVC filter to prevent the thrombus from reaching the heart. Palma operation can be done in iliofemoral thrombosis. Femoral vein below the block is anastomosed to the opposite femoral vein. This is the Palma block. And May-Hussin operation is in popliteal vein thrombosis. Popliteal vein beyond the block is anastomosed to popliteal vein below the block is anastomosed to the long saphenous vein. That is May-Hussin sign. So rest bandaging entire limb with crepe bandage, anticoagulants, low molecular weight heparin, warfarin, phenydione, streptokinase, thrombolytic, thrombectomy using Foley's catheter, IVC filter. So varicose vein is permanent, elongated, dilated tortuous vein causing pathological circulation, risk of reversal of blood through its faulty walls, hereditary, female, prolonged staining, pregnancy, and immobility are all risk factors. So classification: long saphenous vein, short saphenous vein, venous varicose vein due to perforator incompetence. Another classification is thread vein, spider vein, and telangiectasia, small veins in skin around the ankle, dilated red, purple network of veins. You have reticular varices, you have varicose vein. which is more than 3 mm dilated, tortuous, elongated superficial vein. So etiology of varicose vein, you have primary varicosity and secondary varicosity. Primary is congenital incompetence, absence of venous valves, muscle wasting, and Park-Weber syndrome. Secondary is recurrent thrombophlebitis, occupational prolonged standing, and obstruction to venous return. It may be ascites, pregnancy, chronic constipation, iliac vein thrombosis, and tricuspid valve incompetence. So pathogenesis, it can be fibrin cuff theory. Pathogenesis, fibrin cuff theory, you have incompetence of venous valves, stasis of blood, chronic ambulatory venous hypertension, defective microcirculation. RBC will diffuse into the tissue planes. There is lysis of RBCs and release of hemosiderin. Pigmentation will occur, dermatitis will occur, capillary endothelial damage will be there, and prevention of diffusion and exchange of nutrients is noticed. Severe anoxia and chronic venous ulceration will occur. Fibrin cuff theory. Then you have white cell trapping theory, wherein there is a raised venous pressure, raised capillary perfusion will be there, trapping of WBC will be there, inappropriate activation of trapped WBC will be there, release of proteolytic enzymes is done, and endothelial damage and ulceration will occur. Sites of varicose occurrence, you have lower limb, sites of portosystemic anastomosis, vulva, perineum, and pamphiniform plexus of the veins. So investigations, you have venous Doppler, duplex scan, ambulatory venous pressure, and plethysmography can be done. Varicography can also be done. So sign of varicosity, it can be visible dilated veins, pain, cramps, and pedal edema, dermatitis, and ulceration can also occur. You also have saphenopharynx, which is large varicosity in the groin becomes prominent on coughing. You also have pertussis, wherein the elastic bandage is applied and walk around. Develop severe pain, it indicates DVT. Okay. And you have Brody-Trendelenburg test. Vein is emptied, elevated, and tourniquet is tied below the saphenofemoral junction. Patient has to stand, remove the tourniquet, rapid filling from above, saphenofemoral wall with competence. Or after standing, tourniquet is not removed, rapid filling from below indicates perforator incompetence. There's 3 tourniquet. You apply 3 tourniquets, and whichever tourniquet from below and above you remove, so that you find out whichever tourniquet is the perforator problem. Differential diagnosis, you have AV malformation, orthostatic edema, and lymphedema, mixed edema. So treatment, you have conservation treatment. First of all, elastic rub bandage, elevation of limb, reduces edema. Anna boots, which is non-elastic compressive therapy, contains zinc oxide, calamine, and glycerin. It prevents further skin breakdown. And pneumatic compression method also can be done. Drugs, you have calcium dobicelate, which improves lymph flow and reduces the edema. There is improved lymph flow and reduces the edema. Calcium dobicelate. And diosmin, which protects the venous valve and anti-inflammatory action also it protects. And you have toxirutine, which is anti-erythrocyte aggregation agent. You can also perform sclerotherapy, which is injecting sclerosant. Sodium tetradecyl sulfate, STDs. Oh my god, that sounds kind of stupid. Okay. Sodium tetradecyl sulfate. These are home sclerotherapy, injection sclerotherapy, TANS elimination, microsclerotherapy, echosclerotherapy, and catheter directed sclerotherapy. Surgery, you can do Trendelenburg operation, crossectomy, stripping of vein, perforator ligation, strap avulsion of varicose vein, and perforator. So varicose vein complications, you have hemorrhage due to rupture of varicose vein, pigmentation, hemosiderosis, periostitis, thickening of tibial periosteum, venous ulcer, Brazilian ulcer, fibrous ankylosis of the ankle joint, tapes equinovirus, patient walks with the tip of the toe, calcification of the wall of varicose, recurrent thrombophlebitis, DVT. All of these are hemorrhage, pigmentation, periostitis, venous ulcer. Okay. Venous ulcer is a gravitational ulcer, complication of varicose vein or deep vein varicosity. Pathogenesis, DVT, chronic venous hypertension around the ankle. RBC diffuse into the interstitial spaces. RBC lysis occur, hemosiderin deposition occurs, eczema occurs, dermatitis occurs. Then lipomatosclerosis, fibrosis, anoxia, and ulceration. So then moving on, we have clinical features. Site is above the medial malleolus due to presence of more number of perforator. This area is called Gator's zone. Non-healing tender ulcer can be there. Clinical features, eventually it develops into marginal ulcer. Lipodermatosclerosis may occur, which is having a campaign bottle sign, prominent calf with a narrow ankle, and you have fibrosis causing Achilles tendon contracture. Achilles tendon will be appearing contracted. So differential diagnosis, you have diabetic ulcer, traumatic ulcer, and ischemic ulcer. Investigations, you have discharge, culture and sensitivity, X-ray to rule out periostitis, and wedge biopsy to rule out marjolin ulcer. Treatment, you have Biscard method, measures to reduce edema and promote ulcer healing. You have to elevate the leg, you have to provide calf massage, passive and active exercising, and you dress with EUSOL. It's a dressing, I feel. Okay, 4-layer bandage technique also is there. High compression, padded pressure bandaging can be done. Once granulate, you can do split screen graft. Once the ulcer will granulate, you can do split screen grafting. Specific treatment for varicose veins, you have Trendelenburg operation and perforator ligations. Another 40 fucking pages. How many? I do not want to sleep, man. Fuck. You know something? I'll just do Hodgkin's lymphoma. Hodgkin's lymphoma due to infectious mononucleoside, Epstein-Barr virus, HIV virus, genetically monoclonal B disorders, features bimodal presentation, 20 to 30 and more than 50, painless progressive lymph node enlargement, hepatosplenomegaly, and anemia is seen. So it can be staged. Staging is basically one group, more than one group of lymph node on one side, one group of lymph node, more than one group, one side of diaphragm, lymph node on both sides, extranodal involvement. Okay, that is the staging. Hemoglobin percentage, yes sir. FNAC of lymph node, excision biopsy of lymph node is immunochemistry. You have CD15, CD30 and CD45. Chest X-ray to note is mediastinal lymph node enlargement, ultrasound abdomen for abdominal lymph node enlargement, MRI, PET scan for extranodal involvement. Treatment, you have stage 1 and 2 radiotherapy, 3 and 4 chemotherapy. ABVD, you have adriamycin, bleomycin, vinblastine and decarbazine therapy regimen. And lymphedema is basically accumulation of an extracellular lymph. Okay, Kinmoth classification, primary and secondary. You have primary, you have familiar and syndromic. Familiar, you have congenital lymphedema since birth. Lymphedema precox, present at puberty. Lymphedema tarda is present in adult life. Syndromic, you have Turner's, Downs and Klinefelter. Secondary lymphedema, you have trauma, surgery in inguinal block, axillary block dissection, filarial lymphedema, advanced malignancy, post-radiotherapy lymphedema, and tuberculosis and syphilis. All of them will lead to secondary lymphedema. Sites of lymphedema, lower limb, upper limb, scrotum, penis, labia, eyelid, whatever. So clinical features, you have foot swelling, tree trunk pattern leg, and loss of normal perimalleolar shape, buffalo hump in dorsum of foot, squaring of toes, stemmer sign. You have skin over the dorsum of foot cannot be pinched due to subcutaneous fibrosis. So complication, it can be skin thickening, recurrent cellulitis, non-healing ulcer, lymphangiosarcoma, and Stewart-Treves syndrome, which is multiple blue nodes often with ulceration. So investigations, you have venous Doppler, lymphangiography, isotope lymphangiosintigraphy, and lymphofluoroscopy. Venous Doppler you do, lymphangiography you do, isotope lymphoscintigraphy, and lymphofluoroscopy can be done. So treatment, you have compression wraps, manual lymphatic drainage you can do, and surgery. Surgery can have excisional anastomosis and excision and creation of communication. Excision is Charles operation and Homan's operation. Anastomosis is omentoplasty, nodovenous shunt and lymphovenous shunt. Excision and creation of communication, you have Thompson's operation, cyst trunk operation, and Condolien's operation. Cyst trunk is the most important one. Okay, excision you can remove it, anastomosis, omentoplasty, nodovenous shunt, lymphovenous shunt you can make shunts. Excision and creation, you have to creation of communication. Cyst trunk is one of the most important operation for lymphedema. So skin thickening, recurrent cellulitis, non-healing ulcer, lymphangiosarcoma, foot, squaring of toes, stemmer sign, skin over the dorsum of foot cannot be pinched due to subcutaneous fibrosis. Then you have chyluria, which is passage of milky white chylous urine, passage aggravated on after 40 meal. Pathogenesis: obstruction of internal lymphatic vessel leads to high lymph vessel and diversion of lymph intrarenal lymphatics. Etiology: you have filariasis, tuberculosis, urinary infection. Investigation: urine culture study, lymphangiography, and ultrasound abdomen. Treatment is low-fat diet, antibodies, DEC, and ligation of dilated lymphatics. Wrist drop is inability to extend the wrist due to radial nerve palsy. Investigation: X-ray of the part, nerve conduction study. So management is nerve suturing, nerve graft, and tendon transfer. Tumor markers, you can remember hormones: calcitonin, medullary carcinoma of thyroid, human HCG in choriocarcinoma, benign melanic acid in pheochromocytoma. Aflatoxin, you have alpha fetoprotein in hepatocellular carcinoma, neuron specific knowledge, prostatic acid phosphatase in prostate cancer, CD marker, CD15 in ovarian cancer. Skin tumors, you have pre-malignant conditions of skin: Bowen's disease, erythroplasia, querate, Baker's disease, leukoderma, senile or solar keratosis, radiodermatitis, arsenic dermatitis, chronic scar, albinism, xenoderma pigmentosa, CLV, chronic lupus vulgaris, prolonged irritation of skin by chemicals like dye, tar, etc. Squamous cell carcinoma or epithelioma arises from squamous layer of the skin, occurs in pre-existing predisposing lesion like Bowen's disease, UVB rays, chronic scars, solar or senile keratosis, HPV infection, Kangiri cancer, Kang cancer on buttocks due to sleeping on bed to control the cold, open bed, okay. Chronic irritation due to charcoal pot over the abdomen to control cold, okay. And chimney sweeper cancer seen in scrotum due to chronic irritation by tar. These are all squamous cell carcinoma. Bowen's disease, exposure, senile keratosis. Of course, there's another thing, xenoderma pigmentosa. That's scary. Clinical feature: you have ulcerar proliferative lesion, raised and everted edges is there, bloody discharge from the relation, and regional lymphadenopathy can be seen. Variants of squamous cell carcinoma: you have marginal ulcer, it occurs in chronic scar tissue. Verrucous carcinoma, it occurs in mucous membrane. Histology: you have malignant whorls of squamous cells with keratin pearls are noticed. Borders classification is there, it is well differentiated in more than 75% keratin pearls, moderately differentiated in 50 to 75% of them, poorly differentiated in 25 to 50%, undifferentiated in less than 25% of the pearls. Then investigations: you have wedge biopsy from the edge, FNAC from lymph node, CT scan or MRI. Treatment: you have radiotherapy, chemotherapy, methotrexate, vincristine, bleomycin, cisplatin, wide excision clearance followed by screen grafting or flaps. Okay, so prognostic for worst prognostic factors in ICC is tumor size more than 2 cm, inhalation depth more than 6 mm, tumor border is ill defined, lymphovascular invasion is there, associated immunosuppression and poorly differentiation all indicate worsening of the squamous cell carcinoma. Radiotherapy, chemotherapy, wide excision followed by skin graft and flaps. Marginal ulcer is well differentiated SCC, burn and venous ulcer maybe. Features: slow growing, painless in duration, non-tender ulcer, chronic irritation of scar tissue. Investigation: wedge biopsy, MRI. Treatment is wide local excision, and in case of large ulcer you have to amputate. Then you have basal cell carcinoma or rodent ulcer, arises from basal layer of skin or mucocutaneous junction, does not arise from mucosa, aka tear cancer, occurs in areas where the tear comes down. Etiology: it is due to exposure to UV light, exposure to carcinogen, xenoderma pigmentosum and albinism. Most common site is face above the Orngrens line joining the angle of mouth and ear lobules. Above that, it is locally malignant, erodes deeply into local tissue including the bone. Rodent ulcer types: you have nodular, ulcerative, pigmented, geographical and basic squamous. So clinically features: you have a slow growing, non-mobile, raised, beaded SE. Differential diagnosis: you have squamous cell carcinoma, melanoma and acanthoma, keratoacanthoma. Investigations: you do wedge biopsy from the edge, X-ray of the involved part and CT scan. Treatment is radiation and surgery. Radiotherapy not useful once basal cell carcinoma invades the bone, erodes the bone. Surgery: you have wide excision with skin grafting. Cardiosurgery, microscopically oriented histographic surgery. Indications are eroding the cartilage of bone close to eye, recurrent after radiotherapy. Then we have melanoma. You have malignant tumor arising from epidermal melanocyte, Risk factors: exposure to UV light, albinism, xenoderma pigmentosum, junctional nevus, familial dysplastic nevus syndrome, large congenital nevus more than 20 centimeter. You also have family history of melanoma. The various differential diagnosis is given: pigmented squamous cell carcinoma, pigmented basal cell carcinoma, Kaposi sarcoma, and cutaneous hemangioma. So clinical types: you have superficial spreading, nodular melanoma, lentigo maligna melanoma, acral lentigious melanoma, melanotic melanoma, and desmoplastic melanoma. So clinical features: you have you have A, B, C, D, E, U. Ulceration, bleeding, anything. Asymmetrical border is irregular. Color will be varying and diameter is more than 6 centimeter and evolving is changing progressively. This is the most important thing, which honestly it's the easiest and important. Border irregularity, asymmetrical, color will be variation, and diameter is more than 6 centimeter, and it's evolving. It ulcerates, bleeds, and it itches. So different types also are there: superficial spreading, nodular melanoma, lentigo malignant melanoma, acral lentigious melanoma, melanotic melanoma, and desmoplastic melanoma. This I really do not know how to remember. Okay. Differential diagnosis: pigmented SCC, BCC, pigmented BCC, Kaposi sarcoma, cutaneous hemangioma, UV light, albinism, xenoderma pigmentosum, junctional nevus. This I remember. Leave it. Okay, leave it. Familial dysplastic nevus syndrome, important. Large congenital nevus, and family history of melanoma. Albinism, exposure to UV is Bowen's disease. Bowen's disease is different. Sinal characteristics, HPV infection, Kagari, Kang, Chinese maker. Carcinoma of the trachea and plunging another 20 pages and okay. Metastasis occurs through lymphatics, through blood. Distant spread occurs to bone, lung, and liver. Investigations: you have excisional biopsy, FNAC of lymph node. You can do ultrasound abdomen to rule out secondaries in the liver. Chest X-ray to rule out cannonball secondaries in the lung. And MRI-PT urine study for sentinel lymph node biopsy. Treatments: you do Handley's wide local excision. Melanoma on fingers, you do disarticulation. In the eye, you do enucleation. You lose your eye. Melanoma in pregnancy is termination of pregnancy, postpone pregnancy for 2 years if you are alive, unfortunately. Turban tumors, you have multiple cycloma and hydriadenoma. Management is biopsy, wedge excision. Painless, disfiguring, cutaneous swelling. Okay. Kaposi sarcoma is malignant bleeding blood vessel tumor arising from vascular muscle superiosteocyte associated with HHV8. European African transplant AIDS associated Kaposi sarcoma. Europe, Africa, transplant and AIDS. So clinical features: you have multiple reddish blue nodes in skin with ulceration. Lymph node enlargement can be seen. Gobner phenomenon within new lesions on previously unaffected areas secondary to trauma. So new lesions will come, previously unaffected areas secondary to trauma. So investigations: you can do biopsy, HIV test, and treatment: you have radiotherapy, chemotherapy, radiomycin, bleomycin, vein blasting. So moving on, you have skin grafting. It is transfer of skin from one area to the required effective area. It is an autograft. Similar autograft. Okay. Types: you have partial thickness graft, you have full thickness graft, and those are the two things. These partial thickness or split thickness graft SSG, the SN aka Thiersch graft. It is removal of full epidermis plus part of dermis from the donor area. It is indicated in well granulated ulcer, clean wound after skin to close the defect created, wide excision in malignancy and mastectomy. You can do partial thickness graft, split thickness graft, full epidermis plus part of dermis from the donor area. Whereas in full thickness graft, it includes both epidermis and full dermis used over the face, hands, finger and all, removed using the scalpel blade. Okay, look, limitation, it cannot be done over bone, cartilage or tendon joint. Technique is donor area is thigh, leg forearm, forearm. Knife used is Humbly's knife and Down's blade. Humbly you get down, you can say Humbly's knife, Down's blade, and donor area is dressed and dressing is opened after 10 days. Recipient area, graft is placed after making window cuts in graft, which prevents seroma. Window cuts are made to prevent seroma. Graft is fixed and tied over the dressing is placed. Dressing is opened on 5th day to observe for graft take-up. Mercurochrome applied over the recipient margin to promote epithelialization. Mercurochrome. Humbly's knife, Down's blade. Stages of graft intake, you have stage of plasmic inhibition, stage of inosculation, and stage of neovascularization. So stage of plasmic inhibition, thin layer of plasma between the recipient area and graft is present. And stage of inosculation, temporary linking of host area and graft is there. Stage of neovascularization, new capillaries proliferate into the graft from recipient area. So disadvantage of split screen grafting, graft contracture may occur, primary contracture and secondary contracture. So SSG signifies significantly contract significantly once it's taken into donor area. Thicker the graft, more the primary contracture. At the site of graft. Okay, secondary is occurs after graft has been taken up during healing period due to fibrosis. Thinner the graft, more the secondary contracture. So it has to be, you have to balance, you can say. Balance this. Then you have scleroma and hemangioma, hematoma. It prevents the grafts taking up. And non-functioning of sebaceous glands after healing oil should be applied over the area. Loss of hair, blunting or sensation can be seen. Full thickness is whole graft. Sites of donor area, you have post-auricular, post-supraclavicular and groin crease. Advantages, you have good color match is there, no contracture, sensation and functions of sebaceous gland and hair follicles are retained. Disadvantages is useful only for small areas. Then you have facial-maxillary diseases. Almost there. Another hour and a half. 4:30, 3:30. Fuck. No, 4:30. No. Fine. Facial-maxillary diseases have cleft lip and cleft palate. Etiologically, it is familiar protein and vitamin deficiency during pregnancy, rubella infection, radiation, chromosomal abnormality, drug intake during pregnancy, steroids or diazepam. So it's classified as cleft lip alone, cleft lip and palate, isolated cleft palate. So it is completely separated from vomer and nasal septum. Incomplete cleft palate is attached to vomer and nasal septum. It is attached or it is completely detached, separated. It is often associated with other congenital anomalies of cardiac, gastrointestinal, neurological, Down syndrome, Teacher-Collins syndrome, and Perry-Robert Robin syndrome. It may be cleft palate, retrognathia, and posteriorly displaced lung. Okay, not that important, I feel. Down syndrome, yes, gastrointestinal, cardiac, and neurological deficit. You can remember. Stickler syndrome, eye, skeletal, muscular, and cleft disorders. Okay, so problems in cleft disorders, you have difficulty in sucking and swallowing will be there. Defective speech is noticed, altered dentation and cosmetic problems will be there. Recurrent URTI is noticed, and chronic otitis media is also there in cleft disorders, because it has very easy ascending infection. Recurrent URTI, altered dentation, defective speech, difficulty sucking and swallowing. Lasha system, you have classification to explain the features. You have lash, LSH, lip, alveolus, soft palate, hard palate. Complete left is written in capital letters. Incomplete left is written in small letters. What is this one? So lip, if it is there, if alveolus is also affected, if the soft palate is affected, and hard palate is affected. So complete is capital letters. Okay, so treatment, you have Milan's criteria. Rule of 10. 10 pound baby, 10 weeks old, 10 gram percentage hemoglobin. So you can do surgeries. If unilateral cleft lip is there, Milan rotational advanced flap procedure. Bilateral cleft lip is Milikun technique. Hard palate repair is Wardil and Langenbeck repair. Soft palate is Ferro technique. Timing of surgery based on delay technique and sequence. Cleft lip alone, you do bilateral surgery at 5 to 6 months. Unilateral is surgery at 5 to 6 months. Wait 1 second. Give me a second. Protein vitamin deficiency, infection, radiation, chromosomal abnormality, ductic during pregnancy, steroids or diazepam. So cleft lip alone, you need to do surgery unilateral at 5 to 6, bilateral at 4 to 5 months. Soft palate alone, you can do it at 6 months. Soft and hard palate, you have two options. Soft palate at 6 months and hard palate at 15 to 18 months. Cleft lip and cleft palate both are there. You have two operations you have to do. Cleft lip and soft palate at 6 months, hard palate at 15 to 18 months. So again, these names are the most important thing. Milan rotational advancement flap procedure, Millikan technique, Wardell and von Langenbeck repair, and Furlow technique. Unilateral is Milan, bilateral is Mulliken, hard palate is Wardell and von Langenbeck, soft palate is Furlow. Wardell, Langenbeck. Timing is based on delay technique and sequence. Cleft lip alone, unilateral, bilateral, you can do it earlier. Okay. And then you have post-operative management, which is post-operative speech therapy, training for sucking and swallowing, control of infection, dental reconstructive surgery, support, hearing support, control of otitis media, veloplasty, rhinoplasty, and orthognathic surgery, etc. Once I get to salivary gland, I'll skip ahead. I'll finish off breast, then I'll come back and do salivary gland, breast, parafollicular, and then I'll do salivary glands. Maybe I'll just go to sleep. Genuinely, a big chunk of my important things has been done. Only this dentigenous cyst, which is follicular odontome. Odontomes are really irritating, man. They are unilocular cystic swelling arising from uninterrupted tooth. Lower jaw is more than upper jaw. Occurs over the crown of uninterrupted tooth, seen in relation to premolars or molars. Clinical features: you have painless swelling in the jaw. So it can be adamantinoma, dental cyst, osteoclastoma. Also, it can be complication. It can progress into adamantinoma. Investigation: you have orthopantomogram, which is well-defined tooth within the cyst you will find. Okay. So treatment: if it is small, you can do excision of cyst. If it is large, you can do marsupialization and later excision. Uninterrupted tooth should be extracted. Epulis, it means upon the gum. Swelling from the mucoperiostema of the gums. You have gingiva. Classification of types: you have congenital fibrosis, granulomatous, pregnancy epulis, carcinomatous, myelomatous, and fibrosarcomatous. Then you have oral cavity. You have carcinoma of the buccal mucosa or carcinoma of the cheek. It can be squamous cell carcinoma, most common. Mylar, actually, I know I have done this already, to be honest. Melanoma, adenocarcinoma, squamous cell carcinoma, basilarity squamous cell carcinoma, ulcerative, proliferative, and varicose. Okay. Smoking, spirit, syphilis, sharp tooth, species, sepsis. Chewing beetle nut, premalignant condition, leukoplakia, hyperplastic candidiasis, oral submucous fibrosis, symphylated glossitis, lichen plantar. Okay. Carcinogens also lead to this. You have tobacco, haricholin. I'll actually do this later though. Maybe I'll do this later. Before that, actually, I'll just do it off very fast. Biological behavior of the carcinoma of the cheek. Posterior cheek is more than anterior, spreads deeper and involves buccinator, tetrapterygoids, tetramolar trigone, which is the deadliest part. And pharynx, mandible, and skin ulceration and neurocutaneous fistula formation can occur. Infection of the tumor causes fever, foul smelling, and halitosis. So clinical features: you have ulcer, which gradually increases in size, pain if it is involving skin and bone. Halitosis is a release of metacaptan and ammonia due to necrosis of tumor. Anti-gum deformity, loss of central part of the mandible due to tumor excision. Pouting of the lower lip with drooling of saliva. Trismus, it is involvement of pterygoid. Dysphagia is involvement of pharynx. Mandibular and upper deep cervical lymphadenopathy. Fixed lymph nodes you can find. Infiltration into hypoglossal cyst, you have ipsilateral deviation. The same side of hypoglossal nerve, ipsilateral deviation. Spinal accessory nerve, defective striking of the shoulder. Cervical sympathetic chain, you have Horner syndrome. And carotid blowout is compression over external carotid artery, leading to erosion of vessel wall, bleeding from major vessels. So investigations: you have wedge biopsy. It is taken from two sides, taken from the edge as continuous as it contains active cells, not taken from central area as it is an area of necrosis. Histological features: you have malignant squamous epithelium, malignant squamous cells with epithelial pearls, keratin pearls. Borders: histological grading, well differentiated in more than 75% epithelial pearls, moderately differentiated in 50 to 75% epithelial pearls. Poorly differentiated is 25 to 50%. Very poorly is less than 25. Something else had a similar grading actually. I'm forgetting which though. This is epilis, carcinoma of the cheek. Okay. Ulcer, pain, halitosis, antigum deformity, loss of central part of mandible due to tumor extension, pouting of the lower lip with stooling of saliva. Okay. Trismus, involvement of pterygia. Trismus, inability to open the mouth. Dysphagia, fixed upper cervical lymphadenopathy, hypoglossal nerve, spinal accessory nerve, cervical sympathetic chain, Yamaha syndrome, carotid blowout, compression over expanded carotid artery leads to erosion of vessel wall, bleeding from major vessels. Antigum, you remember, halitosis, pain, ulcer, trismus, dysphagia, submandibular and upper cervical lymphadenopathy, infiltration. Infection of tumor area infection causes fever, foul smelling and halitosis. Skin ulceration, neurocutaneous fistula formation will occur. Posterior cheek is more in than the anterior cheek. Okay. Investigations: wedge biopsy taken from two sides from the edge as it contains active cells. Not taken from central area as it is an area of necrosis. Okay. Malignant squamous cell with epithelial keratin pulse will be there. Then you have FNAC from lymph node, fine needle aspiration cytology from lymph node, CT scan to assess the extension of tumor, MRI to assess the extension into soft tissue and perineural spread, and orthopantogram to assess involvement of mandible to see how much the mandible is involved. Then treatment: you have surgery, mandibulectomy, reconstruction after surgery, mandible reconstruction by various methods, radiotherapy and chemotherapy. So wide excision, lip split incision, transversal approach, Patterson operation, neck lymph node block dissection also you have to do. Mandibulectomy, segmental mandibulectomy, marginal or mandibular limb dissection. Reconstruction, you have split skin graft, delta pectoral cutaneous flap, pectoralis major myocutaneous flap, forehead flap and anterolateral thigh flap. Mandible reconstruction you do by corticocalcaneous bone graft from iliac crest or rib cage, fibula graft, radial forearm flap with section of radius, titanium and stainless steel plates. Radiotherapy you have external or brachytherapy. External radiotherapy or brachytherapy. Chemoradiation, intra-arterial, intravenous or oral chemotherapy. Methotrexate, vincristine, bleomycin, cisplatin. EABG also. There are so many things I've already forgotten. Shit. Plunging renal, all this I'll do. Come back. One second. I'll move on to breast next, but I need to check something out. Thyroid is shit. Fuck this shit. I will do it, but Paradrenals, yes, this is important. Breast is important. 2 pages for paradrenal and breast you have around 10 pages. So that will take another half an hour, and paradrenals will take around 2-3 minutes. Actually, it will take 10 minutes. So I'm feeling what more much of time. I'm feeling sleepy now. I'll finish breast finish paradenals. Okay, and then salivary glands is the only thing which is left. Salivary glands and thyroid. That I'll do some 20 minutes before the exam. Okay. Para So starting with breast and $104. God damn it. 8 pages. 10 pages. Basically another half an hour and I'll sleep. Fuck this shit. Main thing is the breast cancer, man. But yeah, classification of breast tumor. You have ductal carcinoma, lobular carcinoma, in situ carcinoma. In situ carcinoma, you have non-invasive, DCIS, ductal carcinoma in situ, comedo, cribriform, papillary, and solid, and lobular carcinoma in situ. Okay, ductal carcinoma, lobular carcinoma, first classification. Second is in situ carcinoma, invasive and non-invasive. Non-invasive, ductal carcinoma in situ, comedo, cribriform, papillary, solid, and LC, I guess. This is a snake. Comedo snake, like a command, I don't know. It's a comedo snake or something like that. Cribriform, sieve, papillary, solid. Solid, so you know. Papillary, something like this. Okay. And you have invasive, which is invasive ductal, invasive lobular, tubular, serous, mucoid, medullary. Okay, so invasive, of course, ductal and lobular, tubular, serous. I'll just draw a liver. Okay, and I will draw bumps. Actually, let's do it this way. Damn. I'll draw bumps. Indicate cirrhosis. Okay. Mucin colloid. You have to remember. Medulla oblongata. Let's see. Medullary. Mucinous, I really do not know. Mucin, maybe. Okay, then you have Pagets disease of the nipple, you have phyllodes, angiosarcoma, and carcinosarcoma. So carcinoma of breast risk factors is you have modifiable risk factors, which is nulliparous, absent breastfeeding more than 30 years at first parity, obesity, tobacco, alcohol, hormone replacement therapy, oral contraceptive pills. So nulliparous are more prone, absent breastfeeding, and late parity also, obesity, tobacco, alcohol, hormone replacement therapy, and oral contraceptive pills. Okay. And non-modifiables, you have early menarche, late menopause, familial history, BRCA 1 and 2, African American woman, and radiation exposure are all non-modifiable. So early menarche and all, you cannot modify that. Early menarche, more late menopause. So estrogen is the common hormone, you can remember it as. More exposure to estrogen because menarche has occurred. Okay. So then you have familial history, BRCA 1 and 2. Familial is the most important. African American women have more incidence of BRCA1 and 2, and radiation exposure. Okay. So etiology, you have mutation of tumor suppressor gene BRCA1 and 2, HER2 mutation, Lee-Fraumens syndrome, which is TP53 mutation, low dietary for phytoestrogens, Cowden's syndrome. All of these are etiology. Okay. Clinical manifestation, you have hard painless lump, most common in 10% cases it is painful lump. You have nipple discharge will be there, ulceration and fungation will be there, axillary supraclavicular lymph node enlargement will be there. So axillary and supraclavicular lymph node enlargement, chest pain, hemoptysis, bone pain, pathological fractures, pleural effusion and ascites will be there. Secondaries in the liver, ovary can be noticed. Cutaneous manifestations, you have putty orange, obstruction of dermal lymphatics, dimpling of the skin will be there due to infiltration of ligament of Cooper, nipple detection, discharge will be there, and tethering to the skin will also be there. Infiltration of ligament of Cooper. Putty orange is due to obstruction of dermal lymphatics. So a hard painless lump. Most common in 10% of the cases it is painful lump. Nipple discharge will be there, ulceration and fungation will be there, axillary supraclavicular lymph node enlargement, axillary and supraclavicular, chest pain, hemoptysis, bone pain, pathological fractures of course, pleural effusion and ascites. Secondaries in ovary, liver and ovary, cutaneous manifestations. Okay. Then for metastasis, you have lymphatic spread is the most common. Hematogenous spread is the second most common way. And going on, you have staging. TNM staging you can have T1, 2, 3, 4 and N all the way up to 3 and M0, M1. M0, M1 no distant and distant, that you can remember. Staging 2 centimeter you have to remember and 5 centimeter you have to remember. 2 centimeter, 5 centimeter. So more than 2, less than 2, more than 2, more than 5, extension into chest corner skin. 2, 5, extension. Okay. Then you have metastasis N1, ipsilateral axillary node mobile, ipsilateral axillary node fixed, ipsilateral internal memory node, ipsilateral infraclavicular nodes, ipsilateral internal memory and axillary node, ipsilateral supraclavicular nodes. That is how it is going. So basically you can remember it like this. First you have same side ipsilateral axillary node and the node is mobile. Okay, that is first one. If it is fixed, it is second. Okay, next axillary it will go, then internal memory will be there, inside the memory internal memory. Then you have infraclavicular, it's going slowly, it's going up, it's going deeper and it's going up. Infraclavicular lymph nodes. Then same side internal memory and combination. Okay, combination is seen. Then ipsilateral supraclavicular. Okay, same side supraclavicular. Below the clavicle, combination above the clavicle, that is 3. Okay, and N1 is axillary node, it's mobile. N2A is ipsilateral axillary node, it is fixed. Ipsilateral internal memory nodes, it is okay, that's it. So M0 and M1 is no distant metastasis and distant metastasis. It is ovary, opposite, breast, lungs, bone, liver and brain. Okay, so investigations, you have mammography, size and location of the mass needs to be done. Microcalcification indicates malignancy. Then you also have FNAC. FNAC is a minimum of 6 aspiration needs to be done. Giemsa, Papanicau, eosin, hemolysin stains are used. in FNAC. Mammography, location, microcalcification, malignancy. FNAC, 6 aspiration, Gimsa papinica, in hemaxillin. Stains are used. Core cut or true cut biopsy can be done. Frozen section biopsy can be done. Excision biopsy can be done. Edge biopsy can also be done. Estrogen receptor studies, you have estrogen receptor positive, estrogen receptor negative. If it is positive, it's a good prognosis. Hormone therapy is beneficial. If it is negative, it is poor prognosis. Hormone therapy not beneficial. Estrogen receptor. Okay, so for that, I just left off. Give me a second. Almost done with this. Okay. Honestly, I'm going to do breast and I'll sleep. I can't do this anymore. And my mobile is heating up like crazy. I've been running this for an hour I thought taking a break. So of course it will be heating up. Okay, so where were we? Estrogen receptor study also you can do. True cut, frozen biopsy, excision biopsy, ledge biopsy, frozen biopsy, true cut. Okay, then moving on, you have progesterone receptor status. You have HER2/neu receptor study of discharge from nipple. Sentinel node biopsy. Sentinel node is first node involved from a tumor, and tumor markers CA15-3. MRI breast PET scan also can be done. Treatment is hormonal therapy, useful in ER/PR positive patient. Tamoxifen, letroxol, trastuzumab, lipatinib, Basically, these are estrogen. Just a second. What is amoxicillin? It is a selective estrogen receptor modulator. Selective SERMs. Selective estrogen receptor modulators. They attach to the receptor. So chemotherapy also you can provide. CAF, CEF, cyclophosphamide is common though. Taxane, cyriamycin, cyclophosphamide, CAF, CEF, CMF, TAC, taxanes, idiomycin, and cyclophosphamide. So CAF, cyclophosphamide, idiomycin, 5-fluorouracil. So 5-fluorouracil. Here it is CMC technically. It should be CMC. Cyclophosphamide is important. Okay, first line is cyclophosphamide, methotrexate, 5-fluorouracil. Oh, okay. This is 5-FU. So 5-fluorouracil, methotrexate, both are common in everything, and you have addition of 5-fluorouracil and idiomycin, epirubicin. Okay. I'm going to do chemotherapy screenshots. I'll do for this one, and I'll do for squamous cell carcinoma also I have to do. Yeah, there was ABER, this thing, adriamycin something and all was there. It was there. Okay. Radiation therapy, you have whole breast radiation therapy and accelerated partial breast radiation. Surgery, you have simple mastectomy, modified radical mastectomy. So simple mastectomy is prophylactic, it can be there, extended simple may be there. Nipple areola sparing mastectomy also can be there. You have platelet modification in modified mastectomy, platelet modification where everything is removed. Everything. Three and supramedially. Three and supramedially is a king. So platelets is the only thing you remember. Our chin close modification. Scalon modification is this one, something is different, and advantages is structure is preserved, pectoral is major is preserved, axillary vessels is preserved, cephalic vein is cephalic vein, not queen. Cephalic vein is preserved, long thoracic nerve is preserved, and thoracodorsal nerve, nerve to latissimus dorsi is preserved. Shoulder function is preserved and better cosmetic appearance. Axillary fold is also preserved. Okay, pectoral is minor is removed. Level 2, 3, 1, 2, 3 nodes are preserved. Then you have finally mousing breast fibroadenoma, most common benign tumor of the breast. Hyperplasia of single lobule of the breast. Focal increased sensitivity to oxygen causes the this situation. You have periauricular hard type or intra-auricular soft type. Hard type is small fibrous tissue, easily felt firmness, moves freely, which is breast mouse, slow growing, painless, and enucleation is possible. Intracanaliculaar is large granular, less firm, rapid growth and painful. Enucleal is impossible, excision is needed. So clinical features, you have freely mobile, firm swelling, most commonly in the lower part of the breast, no discharge from nipple, no axillary lymph node involvement. None of them will be there. Freely movable, firm swelling, most common site is lower part of the breast. Lower part of the breast it will form, no discharge will be there. Investigation, you can do mammography, popcorn calcification will be there, FNAC, core biopsy can be done, and ultrasound MRI can be done. So management, you have excision, removal of tumor along with capsule, leaving the capsule behind. Enucleation you can do. Incision, you have SAB, memory fold, periareolar, and radial or curved incision. So it can be radial, it can be periareolar, or it can be SAB. Giant fibroadenoma is more than 5 centimeter. You have to remove by submammillary incision. And D, aberration of normal development and involution. And D. So it includes variety of benign breast disorders occurring at different reproductive periods. So based on 3 phases of physiological changes in breast, you have lobular development, you have cyclical hormone modification, and you have involution. Abnormal development and involution. Okay, so types, you have 1 in the early reproductive age group 15 to 25, fibroadenoma, stromal hypertrophy. 2 in mature reproductive age group, you have cyclical mastalgia, fibrocystadenoma. And 3 involution in age group 40 to 55 years. You have early age group, you have fibroadenoma, stromal hypertrophy. Mature reproductive age group, you have cyclical mastalgia. Involution age group, you have lobular involution, fibrosis, adenosis, apocrine metaplasia. You have ductal involution, periductal mastitis, mammillary duct fistula, partial nipple retraction, and you have epithelial changes, hyperplasia and atypia. Okay, few more topics are there, but 3:30 has already occurred. I think you can see. I'll do phyllodes and I'll do few other things. Phyllodes is a cystosarcoma phyllodes, tumor of mixed connective tissue and epithelium, systemic disease of Brody, benign borderline malignant it can be. Age is more than 40 years, rapidly grows into basellated mass, smooth, non-tender, fluctuant swelling, skin over the breast is stretched, visible dilated veins can be seen. It can be fibroadenoma, angiosarcoma, carcinoma of breast. So gross examination, you have massive tumor with basellated surface, multiple areas of necrosis and cystic changes is seen. Microscopically, you have epithelial cleft resembling a leaf-like structure. That's why it's called phyllodes. Okay, and investigation, you have mammography wherein you see calcification and necrosis. Ultrasound, you have cystic spaces. Treatment, you have small phyllodes which is excised along with 1 centimeter margin. Large phyllodes, you do mastectomy with adjuvant chemotherapy, excised with 1 centimeter margin. Okay, then sentinel lymph node biopsy, you have sentinel node is the first node involved from a tumor, used for carcinoma of breast, penile cancer, and malignant melanoma. Okay. Then if sentinel node has no tumor, it indicates no need for extensive lymph node dissection, done when lymph nodes are not detectable clinically or by imaging. Contraindication, T3, T4 lymph tumors and inflammatory breast cancer and pregnancy. Okay. Then Paget's disease will do. Paget's disease is superficial manifestation of intraductal carcinoma. Superficially, whatever it will manifest is Paget's disease. Malignancy spread from duct to nipple. So you have an hard nodular underneath areola. Ulceration and destruction of nipple will be there. Unilateral, yeah. Unlike eczema, it is bilateral, which is bilateral. Okay, eczema is bilateral. It is unilateral. It is unilateral in Paget's disease. It has distinct edges and itching is absent. It can be eczema, of course. So investigation, you do biopsy. Okay, large clear Paget cells within the malignancy features. Paget cell contains intracellular mucopolysaccharide, clear halo in cytoplasm. Treatment is modified radical mastectomy. Triple assessment, of course, is clinical history and examination, radiological imaging, MRI, ultrasound, mammography, and cytological histological analysis, FNAC, true cut biopsy. Clinical, radiological, cytological. Honestly, even I think you guys notice that even my display just darkened. My mobile is kind of gone. It's having daylight sensors have been tricked in. Power saving mode has been activated. Okay. So breast abscess, antibioma, gynecomastia, Mondor's disease, ductal ectasia. Okay, I'll finish the. Honestly, I want to finish this also. I want to finish breast and parathyroid, parathyroid and paraadrenals because they're all very very big topics. Then tomorrow I can finish off easily thyroid glands. Thyroid I'll finish off before the exam, and salivary gland, thyroid, salivary gland, thyroid. Okay, let's just finish it off. Mastalgia is pain in breast. You have chest wall pain, cyclical pain related to menstrual cycle during menstruation, and the treatment is diclofenac, evening prismarinol, tamoxifen, and analgesic. Non-cyclical periductal mastitis, malignancy, THC syndrome, Mondor syndrome, cervical root pain treatment, identification and treatment, of course. Okay, breast abscess is precipitated by cracked nipple, retracted nipple, improper cleaning of nipple, infection from mouth of baby, hematoma getting infected. So infectious agent is SRS, epidermis, streptococcus. Clinical features: you have a continuous throbbing pain, diffuse redness, brownie induration in the breast, purulent discharge from the nipple, palpable axillary lymph node. So it can be inflammatory carcinoma of the breast. Okay. Investigation: CBC, USG breast, and ultrasound guided aspiration. CBC you can do, ultrasound breast, ultrasound guided aspiration. Treatment: you have antibiotics, cephalosporins, penicillin, drainage under general anesthesia. Complication: antimyoma formation, sinus formation, skin necrosis, and septicemia. Antimyoma is pus in inflammatory mastitis, localizes and becomes sterile with thick fibrous tissue cover. Features: you have mastitis treated only with antibiotics without drainage. Pain is swelling, tender, and non-fixed. Differential diagnosis: you have serous carcinoma of the breast. It can be there. Okay. Investigation: FNAC, US ultrasound breast, and treatment is excision with submammary incision. Then you have gynecomastia, enlarged breast in male due to can be physiological, estrogen excess state, androgen deficiency state, testicular failure, and drugs. Complications, of course, is breast cancer. Of course, grading also is there 1, 2, 3, and management is testosterone therapy, danazol. Surgical treatment is local excision, liposuction, and subcutaneous mastectomy. Etiology: physiologic gynecomastia, neonatal period, adolescence, innocence. Estrogen excess state: you have testicular tumor, endocrine disorders, hermaphrodites, and liver cirrhosis. Androgen deficiency state: hypogonadism, Klinefelter, and ACTH deficiency. Testicular failure: you have trauma, radiation, orchitis, undescended testis. In drugs, you have furosemide, spironolactone. These both are most common. Ketoconazole, cimetidine, captopril, and isoniazid acid are other drugs. Okay. Testicular failure, trauma, radiation, orchitis, undescended testis. Klinefelter, ACTH disorder. Estrogen excess, testicular tumor, endocrine disorders, hermaphrodites, liver cirrhosis. Physiological gynecomastia, neonatal period, adolescence, and senescence. Then you have Mondor's disease, which is string phlebitis. Thrombophlebitis are superficial veins of breast and anterior chest wall. Involves vein. You have lateral thoracic vein, thoracoepigastric vein, superficial epigastric vein. Lateral thoracic vein, thoracoepigastric vein, and superficial epigastric vein. Mondor's disease. Thrombophlebitis, superficial veins of the anterior chest wall, lateral thoracic vein, thoracoepigastric vein, superficial epigastric vein. Examination: you have thrombosed cord-like vein attached to the skin, forms grooves over the skin upon lifting arm. So it can also be lymphatic permeation of carcinoma of the breast. Treatment: you give warm compression, brazier support, and excision. Also, ductic tissue, dilatation of breast duct associated with periductal inflammation, plasma tumor, smoking, multiple pregnancy, greenish discharge from nipple, induration mass, secondary retraction of discharge of NSC, quit smoking, Halfield operation, cone excision of the involved major parts of the duct, smoking, multiple pregnancy, and hyperprolactin. Increased prolactin will lead to periductal ectasia, dilatation of breast ducts with periductal inflammation, plasma cell mastitis, smoking, multiple pregnancies, hyperprolactin. Prolactin will be increased. Greenish discharge from nipple, indurated mass under areola, diffraction of nipple, secondary bacterial infection. Carcinoma of the breast also can occur in differential diagnosis. Discharge you do study, FNAC, mammography you do. Quit smoking, cone excision of the involved major ducts. Okay. Tendency syndrome, Modo syndrome. This is breast has been done, parathyroid and adrenals. You have to do MEN syndrome, which is autosomal dominant inherited endocrine syndrome complex. MEN1 is Werner's disease. You have parathyroid tumor, which is hyperparathyroidism. Pituitary tumors you have, which is hyperprolactinemia, acromegaly, and Cushing syndrome. Pancreatic islet cells tumor, you have gastronema, glucagonema, insulinoma, VIPoma, somatostatinoma. MEN2 also is there, MEN2A, MEN2B. MEN2A is Sippel's disease, medullary carcinoma of the thyroid, pheochromocytoma, parathyroid adenoma, and cutaneous lichen amyloidosis, spring disease. Spring, cutaneous lichen, parathyroid adenoma, pheochromocytoma, medullary carcinoma of the thyroid. MEN2B is medullary carcinoma of the thyroid, pheochromocytoma, mucosal and gastrointestinal neuroma, marfanoid features. So evaluation, you have family history, biochemical screening, you have parathormone, serous calcinoma, serum calcium, prolactin, growth hormone, insulin, glucagon, and calcitonin. Genetic screening from isolated DNA from peripheral blood, WBC also can be done. You also have system B scan, which is a technetium 99 labeled scan. Helps in adequate localization of parathyroid adenoma. Surgeons can use a minimally invasive surgical approach, often combined with SPECT, single photon emission computerized topography. Tetany is decreased level of calcium in the blood causing its effect. It can be after thyroidectomy, decreased parathormone, hypocalcemia. Decreased calcium in the blood, injury to parathyroid blood supply, D. George's syndrome, wherein there is absent parathyroid and thalamic aphasia also will be there. Thymic aphasia also will be there. Rickets, osteomalacia, metabolic alkalosis, and chronic renal failure can also be the etiology. Clinical features: you have paresthesia of neck, finger, and toes, corpopedal spasm, generalized weakness and twitching, stridor and breathing difficulty due to paralysis of the respiratory muscle. Toss of sign: you have upon tying tourniquet and raising the BP, flexion will occur, and extension at intraphalangeal joints. Chokoscopic sign is tapping over periauricular region leads to teaching of facial muscle. Prolonged QT interval will be there. Management: IV gluconate, oral calcium with vitamin D, and magnesium sulfate therapy. Brother, these people have not given adrenal glands. Adrenal glands. VEM and all is there, man. Vinyl malonic acid. So many things is there. Pheochromocytoma. Shit. Pheochromocytoma is not done. Thyroid I'll do tomorrow. After waking up, I'll do cold abscess. No, this cold abscess I remember very well. Submandibular gland I need to do. Fraze syndrome also I remember a little bit. Pleomorphic adenoma I have to do. Cystic hygroma I have to do. And bronchial fistula. Tuberculosis I remember. Carotid body tumor also. Neck, salivary glands, and thyroid, and adrenal. Those 4 topics I need to do. I'll do it tomorrow. For now, yeah. See you guys. I'm genuinely tired. I'm done. I'll sleep. I'll go wake up tomorrow and I'll do. Done.